Super. So I think everyone's been admitted now. Hello, my name's Helen Hughes. I'm Chief Executive of Patient Safety Learning. And welcome everyone. I'm just going to go through the format of the session, but just to let you know that we are going to be recording today, so that we're able to share with people that aren't personally able to attend, and we will try and get that out next week. Fantastic joint webinar between the Patient Safety Commissioner and Patient Safety Learning around engaging patients for patient safety, which is the topic of the World Health Organization World Patient Safety Day, the 5th Patient Safety Day. So I'm going to just introduce the format. We've got four, well, I was going to say wonderful panelists, but I'm one of them. So 3 wonderful panelists and myself are going to be doing some reflections on this last year, some of the progress to date around engaging patients, some of the positives and some of the barriers, and what next for the next 5 years. So we're going to be doing that in sequence, and we probably won't take much more than about 30 minutes. That's the plan, so that we can actually have as much as an interactive discussion as possible with all you wonderful people that have joined us. And so please, because we're not going to be inviting you to present or to talk your questions, but in the chat, as much of comments or questions we'll pick up. And if we're not able to address them all today, we will try and ask people to respond to those and let those be known sort of shortly thereafter. So before we start, Henrietta and I got the privilege of actually being in Geneva. So for World Patient Safety Day, WHO have been organising some events on engaging patients. So Henrietta, do you just want to give participants a little bit of an insight as to what we've been doing? Because I think that will interest this audience.
Yeah, thank you so much, Helen. And I want to also say a very warm welcome to everyone who's joined the webinar today. Thank you so much for giving up your time. By doing that, you're already demonstrating your leadership in seeing how elevating the voices of patients and listening intently and with fascination and curiosity to what you're hearing is a really important part of improving the safety culture in the health system in England. And listening to patients and families, particularly those who've experienced harm or severe harm or even the death of a loved one, has been a really core part of what the conference for the first 2 days and now the second part of that has been with the WHO. And what my reflection is that the similarity of the themes that are coming up from countries all over the world shows that this is bigger than a problem in England. This is a global issue, and one where we need to really be open to the innovations and the initiatives that have been done in different countries around the world, so that we can then import that into the way that we support listening and acting on what patients and families are saying. So thanks very much, Helen.
Henrietta. So what I'm going to do is we're going to go in sequence, and I'll introduce each of our panelists in that sequence. But what we've asked each panel member to share their reflections in 5 minutes. I'm going to keep an eye on the time on the past year of patient engagement and patient safety, considering where there's been progress to date and what do they see as the current barriers to that progress. And we start with Jono. Both Jono and Tracey clearly wear multiple hats, but I'm going to introduce you as a patient leader, which you are, and a member of the Southwest Personalised Care team. But you can describe as many of those hats as you like, Jono, and you have 5 minutes to tell us your reflections.
Helen, thank you very much, and a great privilege to join this combined webinar between yourself at the Patient Safety Hub and Henrietta from the Patient Safety Commissioner, and I thank you for the invitation. I think you guys have said you see a lot of thank yous in Geneva, and you mentioned that it presents a culture of openness and inclusion, and also a warmth, and that's actually one of the improvements I've seen in the last year, is that there is a much more warm welcome to people presenting their lived experience. As we've had a bit of a pre-conversation, that the standard term seems to be their patient story, and that also is one of my first challenges. I hear quite frequently from patients And I also think myself that using the term a patient story is not actually the best way to describe what we bring. What we bring is lived experience. We bring evidence of our experience to the conversation. And very much we bring, hopefully, an open challenge that says, together, we can do things better. I think most of the people I see in the wonderful roles that Tracey has taken up as a patient safety partner come with a real openness and a desire to work together to see benefits not just for patients but also for staff. And I think that is being seen much more richly in the world of patient safety too. The year's been an interesting one. There have been some interesting debates, interesting reports out. And one of those was the deaths in mental health services report, which made a very significant recommendation. And that recommendation was that all mental health trust boards should consider having a patient with lived experience helping to represent the patient voice on their boards. And I think that is the right way to see that patients are involved at the most strategic, most important level of decision making. And how we do that is exactly the same way as we would recruit a non-executive director or an executive director. We need to ensure that the right person with the right skills comes and uses their voice for the benefit of all, not the benefit of a single voice. And so that's really important. The same recommendation, however, was made by NICE in the shared decision-making policy nearly 2.5 years ago. And as of this moment in time, only 2 trusts that I'm aware of nationally have recruited executive patient directors with the specific task of looking after patient stories and looking after lived experience and shared decision making. So that what I would say is my thoughts in the last year is that we have seen an awful lot of really good policy position for strategic involvement of patients. We have not necessarily seen that policy position taken up as much as I would hope. And it is really important that we advance this as much as possible. And then we look at the second part of the National Patient Safety Strategy from 2019 was very, very clear that we need to involve patients in their own individual care and their own safety whilst in the care of the health service or in the care of social care. And I again think we have seen some great advancement on that. I will be slightly snarky and say there was a rather tacky video produced by the national team that said, if you bring your own slippers and bring your own medicine, all will be safe, which was not exactly the best response to involving patients, because what I want to see is the deep involvement of patients in their personal care via the clinicians directly. And one of the ways I think that that can happen is if we start to have multidisciplinary team meetings that involve the patient and actually involve patients in a real meaningful conversation about what it is to be safe and to understand what safe care is for themselves in this world that we now live. So, yeah, I am really interested in seeing the advancement over the next year, and I think we've done some amazing things this year. There is still, though, a long way to go. I know you guys are at the World Health Organization conference. There have been some great information and data shared there, which I know will be coming out later on, so I'm not going to go into the detail. But even the data from the World Health Organization says we still have a long way to go if we're really going to put patients at the center of patient safety and at the center of what we need for them to have good, high quality, safe care. It's been a good year, and we're going to continue to have good years. And I think we're going to continue to have them because we will involve patients more as we go on. Henrietta, you also recently announced that you have been asked by the minister to invoke and look much more at Martha's Law. And again, I think those sorts of involvements of patients, their families, their carers in ensuring that when a patient doesn't feel that they've got the best care, that they can seek second opinions and they can seek redress, I think is absolutely the right thing to start to do. So yes, let's do some more at national level, at local level. And most importantly for me, a big thank you to everybody on this call for being so passionate about patient safety. Thank you very much. Helen, over to you.
Superb, Jono. Thank you very much. And apologies for the background noise. And I've managed to come downstairs, so slightly. So hope that wasn't too distracting for you all. So we'll pick up some of those themes, Jono, in a second. But I want to pass now to Tracey. Again, multiple hats. So Tracey, you're a patient safety partner. You'll say more about that. And I know you've been in place for about a year at the Central and North West London NHS Foundation Trust. But over to you.
Thank you, Helen. And to echo what Jono has said, it's an absolute privilege to be here today. And I have to say, it's a true demonstration of the trust, and not the National Health Trust, but trust in individuals, in a person like myself. So I don't have a medical background. I have not worked at the NHS. I am a CEO of a small charity, and I work with and support bereaved families where they have lost their loved ones, as well through serious crime. I saw this role, it arrived in my inbox, as many things do, world of a very busy CEO, and I just read it and I thought this seems like an absolute wonderful opportunity to work that I do anyway. We often find that patients that come to us at the trust have felt that their trauma has been compounded due to the very nature of having to share their lived experience and what they're going through from one department to the next, depending on what service provisions they're seeking within the trust. And I felt that we could further benefit them and their help, and working alongside the Victims Commission of London and supporting victims throughout London. I just felt that these two things combined would give patients a much stronger voice. And I have to say, my experience to date, coming into a role that I knew very little about, other than my passion is about safety. It's about people feeling confident and safe in a space where that is their safe space. They should feel confident and safe there. And being able to have a common language with a professional, because quite often terminology and that can be a real barrier to people moving forward. The team at Central North West London, the safety team, in fact, the whole board, right up to quality committee, have been so welcoming. And dare I say, I'm sure with any organisation, new person starts, and that's going to bring the voice of the patients forward into many executive board meetings and quality committee meetings. It can be, I guess, what is she going to come with? What are we going to hear? But I was given that platform to speak freely and honestly, and to share the voice of all of the people that we support. And that was just absolutely inspirational. And further to that, even joining this panel today, the call went out, would a patient safety partner like to join? And I just thought, well, I'm sure hundreds will say yes. And I said yes. And I was accepted on with no question, no in-depth interview. I'm here today, as you see me. Really, there's been no preparation. I haven't been vetted or told what to say in any shape or form. And that is super, super refreshing. And, through my role so far to date, I've been part of supporting 2 staff videos around the benefits of patient safety. And why compassionate engagement is so important. And it helps the patient enormously, but also the staff member. They want to feel safe as well in their role, right? And they want to have this open conversation that's not going to end in sort of somebody leaving feeling unhappy, frustrated, disgruntled, angry, indeed, because it's just compounding the trauma further. So I've been involved in that. I have been invited to all the patient safety incident response framework meetings. I've been part of the PSSI team, helping to develop more work around the patient's voice in serious instances. There's been a huge amount, actually. It's really been full on, the role, and yeah, it's very, very positive. And I just want to reassure anyone that's listening today that, patient safety partners that I've met so far, they are super, super passionate about bringing about change, positive change, and indeed in line with the World Health Organization and our partners in Geneva. Some of these barriers, I guess, for us, or for the trust, should I say, has been, this role kind of, it wasn't really specific, if you like. It's been more sort of generic. We're kind of finding our feet. I don't see it as a disadvantage. It could be a barrier, but I see that as something positive, actually, because my voice is being heard and we are making things happen through the patient voice. We're keeping the patient perspective at the forefront of what we're doing and working towards, which is super, super important. Obviously, that's why we're here. But and it's been heard, and I can't thank the team at CNWL enough. I mean, proof is in the pudding. Okay, so if they're welcoming me in as a service user, as a bereaved mum from the most, challenging times, and a CEO of my own organisation, my own charity, they haven't seen any conflict. They haven't felt that this would not work. In fact, it's just been positive all the way. Yeah, and I guess that's my bit for now.
Thank you, Tracey. That's fantastic. I'm going to pass to Henrietta and just to say, your reflections on the last year, because it's been quite a year for you. So over to you.
Yeah, thanks ever so much. And Tracey, I'm so pleased to hear about the warm welcome that you've received and the way that you're able to work with the frontline, with other patient groups, with other members of staff and the board. And that's really, I think, the whole kind of aspiration of the role of the patient safety partner. And it'd be lovely when there's more of you so that you've got, a buddy, a pal, to be able to bounce those ideas off. Yes, so the last year for me, well, I started in this new post 1 year and 3 days ago. So it has been a bit of a roller coaster. But one of the things I've massively enjoyed doing is meeting with patients and families, meeting with patient groups, representatives, whether that's the parliamentarians or charities, and seeing this kind of yearning desire for the voice to be heard. And at the same time, working with the providers, with clinicians, with Royal Colleges, and seeing that there's a real desire to work in partnership with patients as well. So where are the barriers? I think we know that there are barriers, including time. People are really busy. There's, lots going on, and it's really difficult, I think, sometimes for members of the public to find the time to be able to get involved in the way, and that includes the whole public. So there is definitely an inequalities issue here in terms of the most vulnerable groups, the core 20+5, may not have those opportunities to get their voices in or even know that there's an opportunity to do that. And I think that's something we really need to work hard with faith groups, with charities, with others, so that we can listen to the voices of lots of people and make sure that we get it right for those groups who are most underrepresented. The other thing which I think has been really interesting is working with parliamentarians. So my role, set up as a result of the Cumberledge Review, was about promoting the patient voice, the value of listening to patients, and promoting patient safety in relation to medicines and medical devices. My role is independent and it's accountable to Parliament. And what I've really noticed is that how much passion and enthusiasm there is in parliamentarians, both in the House of Commons and in the Lords, but also I'm seeing a real change in the mood music, I would say, coming from ministers. So, working closely with ministers, meeting regularly and seeing the little chinks of light opening up where they maybe weren't there before. One of the recommendations from the Cumberledge Review was around a redress body for patients and families who'd been harmed through the use of pelvic mesh, sodium valproate and Primodos, a hormone pregnancy test. And I've been asked to look at redress options for patients harmed by pelvic mesh and families affected by sodium valproate use in pregnancy. I see that as a real step change. It's a chink of light in terms of recognizing the impact of harm on patients and families, not just on the people who are harmed, but on those around them and the intergenerational impacts that this can have, with stigma from disability and from other conditions as well. The other thing, as Jono mentioned, is around Martha's rule, and I think that there's this is still very early stages, so I can't go into a huge amount of detail, but very much that idea that, yes, if you are worrying about your family member, what is the opportunity to flag this and how will your voice be heard? And I think that we can learn from international examples such as Ryan's rule in Western Australia, but other examples that have already been started across England, and learn, from those exemplar organisations. So I start with the position of patients having more knowledge about their own care, and working with a task force from pharmaceutical companies, academic health and science networks, regulators, patient groups, to reimagine the medicines information, to move beyond that piece of paper that you unfold till you can wallpaper your bedroom with it, which personally I can't read without my glasses on, and then think about how that can be presented in a way which is more user-friendly, more patient-friendly, because ultimately it's the person who's taking the medicine who needs to know about it, to know what the side effects, the benefits, the color of the capsule, I don't know, all of those details, so that they can be absolute partners in their care. The other area which I think is really interesting is the medtech strategy, and that's being led through the Department of Health and Social Care and the Office of Life Sciences. And this is about getting the right product in the right place for the right price. But I question, what do they mean by the right place? Do they mean the clean utility, next to theatre? Or do they mean in the right person, in the right place, in the right person, and the product which is designed to meet the needs of that individual? We've seen examples, whether it's to do with pulse oximeters used in people who've got darker skin tones who are not so effective, or heart valves, which are designed around the men's heart valve size, not a woman's heart valve size. So there's a lot here that needs to be done in terms of bringing in the views and voices of patients in their own care, working in governance in trusts, but also at a more national level, thinking about the value and importance of engaging patients for patient safety.
Super. Thank you so much, Henrietta. I'm going to reflect a little bit from patient safety learning, and before we go into the what do we want to see in the next 5 years, and then we can have a bit of a debate. And there have been comments and questions in the chat, which is fantastic. So I will draw on some of those, but do keep those coming. So from a patient safety learning's perspective, there's been a lot of progress. I mean, clearly following Henrietta, you're now in post. I was on the patient reference panel for the IMMDS review, and it's a significant move forward that the appointment's been made, and that you're establishing the office in a way that is doing so very credibly and influencing, because you have, I know, limited official powers of information gathering and recommendation, but it's those soft influencing networking that will really bring a lot of people with us and a lot of change to get the patient engagement at the heart of kind of decision making at a policy level, right the way through to a decision making in terms of shared care. So we're seeing, I think, the commitment for patient engagement and patient safety that's embedded within the national strategy that came out 2019. I think, Jono, you've all three of you picked some of that up, the framework for involving patients, and that's now being realized. We've had a difficult time clearly during the pandemic. That may have slowed a little bit down, but it's now stepping up, I think, with the patient safety partners, and we're delighted at Patient Safety Learning to be able to help create or support the network of patient safety partners, which we can put more details in the chat if any patient safety partner would like to join that as a mechanism, as a community of practice, and as a sharing information, visioning, and some peer support. Big changes in PSIRF, in the patient safety incident report framework, and I suppose kind of going on to the barriers, it's the point that you made, Jono. The policy commitment is there, but needing to realise it, and some of that is the personal commitment of leaders, and some of it will be resourcing. There are very disparate responses to patient safety partners, and many have got Tracey's experience of being very welcomed and supported. Others are a bit sort of, oh, we've got partners now, what do we do with them? And I think there are fewer of those, but we need to help organisations by sharing that knowledge. So I think it's a difficult environment because we're healthcare and the NHS is under enormous strain in terms of how busy it is, the burden on staff. And just a little reflection as we go through, I think you've all reflected, and Jono and Tracey very powerfully, that this is about patient engagement, but it's about staff and staff engagement and staff support too. So that reinforces the World Patient Safety Day commitment 2 years ago, which was staff safety, patient safety, two sides of the same coin. So it's great to see that becoming much more of a kind of realised expectation. It's not two separate silos that need to be joined together. It is the same agenda. But I think one of the things that is it is a bit of a missed opportunity at the moment, and I would like to see more of this. And I will be saying some of that in a meeting later on, which is getting the perspective from individual patients or family members of their experience. But how do we capture the insight from the collective wisdom, the Facebook groups, the hive minds of people that have united to create a sort of campaign? And obviously that Henry, you mentioned about the campaigners for MESH, sodium valproate and Primados. It is getting that collective view, not just the individual voice. And I think there are some people from the campaign against painful hysteroscopy on the chat, which is fantastic. But we've been working and trying to support these groups along COVID support as well as Sling the Mesh. So we're capturing those voices. It's not just the individual perspective that organisations need to hear if they find mechanisms to embrace those collective views. So I think there's an opportunity to engage with those groups and to listen and learn. And it's not always clear how they can best get their messages over and address what Jono highlighted, which is effectively an implementation gap often between policy and reality. So there's commitment, there's policy, but it's actually making it happen on the ground. So I've weaved in a few sort of the comments, but I'd just like to go back to the panelists in the same order, if that's all right with you. Just to, a couple of minutes, what needs to happen in the next year, 5 years, to ensure patients are effectively engaged and involved in patient safety. A bit of a magic wand. What would you like to see? Maybe 2 or 3 just key points, and I'll start with you, Jono.
Okay, so I'll start with the concern of the moment, and it is slightly political, but you'll understand. It is not possible to keep patients safe if there are not the right people to treat them and the right numbers of people to treat them. The RCN have made clear that a number of nurses of 1 to 8 is not right. We should be looking at 1 to 6. It's obvious at this point that we also have major strikes going on in the NHS from the clinical side, and the most worrying one for me coming up is, of course, the joint strikes between consultants and juniors at exactly the same time, which I really do believe that that's actually irresponsible, because it will cause harm on those days. I know as a patient what it's like to be in the very first week of any junior doctor's rotation as a patient, and know what it's like to have an arrest during that time, where nobody knows where anything is or what anything's doing, and it will, I believe, cause real concerns. So the first is we have to get our staffing right. We have to get our recruitment right, and also we have to get our retention right. And the reason that people are leaving the NHS is because they do not feel cared for, they do not feel supported, and we need to do better at that. And I think that is one key thing for patient safety as we go forward. The other is to implement what we say we're going to do. It is often a major delay and lag between policy and implementation, and also when we listen to patients. I described earlier a time I had as a associate board member to Henrietta and to Helen, and that was we had a patient come and talk about a very harrowing story, lots of things going on, and at the end of the patient giving their story, they were told, thank you very much, we're going to do other things now if you'd like to leave. And as the patient left the door, somebody from the board made the comment, well, now we can get on with the real work. And that is heartbreaking to hear. And I'm grateful to hear Tracey saying that's not currently happening in her organisation. And actually, we hear much more about really positive things going on with the listening to patients. And I think that the point I raised earlier around understanding that this is a partnership means also understanding that a patient's experience is no different in value to a clinician's experience or to a manager's experience or to anybody else that presents information to a board or to an organisation. And so my ask in the next year, and in fact longer than that, is that we start to equalise the value in our organisations between a patient voice, a lived experience voice, and the voice of clinicians and managers within an organisation. I think I'll leave it there. Thank you very much, Helen.
Thank you, Jono. Tracey, your wish is 1 to 5 years.
Wishes. Okay. Well, we have plans.
Oh yeah, well,
so
even better.
So for my role within the Central and North West London Trust, it's to further support the patient safety partner role. There needs to be a lot more visual awareness around the roles that patient safety partners actually hold within the trust to give patients far more confidence that they are being heard, that they are being listened to, that there is somebody that they can reach out to that can amplify their voices to prevent this compounded trauma that we talk about quite a lot at CNWL. To engage further with the Patient Involvement Forum and Carers Council, that's definitely something that I would want to do more of. I guess more training really would be helpful from NHS England around my role as well. And I just think the national network, you've mentioned that, Helen, we talked about that previously in a patient safety partner hub meeting. I think that would be really just a super positive thing to roll out nationally, so that there's this big hello patient safety partner presence with training that supports those roles, and a uniform training, if you like, so that we're all on the same page. And for those of us that maybe are a bit further ahead in our organisations and seem to have more access, especially from quality committee meetings, right to meeting several department leads and having intimate conversations with them about their provisions. That can happen for all patient safety partners in whatever organisation they're working in, because I have heard that there are others that might not have that kind of access and that freedom to move around. Yeah, so for me that would be absolutely wonderful. And dare I go to funding, but I will, because it's really important and I can't sort of skirt around that, is for there to be more funding so there can be a patient safety partner at CNWL. And we need hundreds more. And I think that needs to be seen to be an improvement from the trust to show that is exactly where we're moving towards, that open conversation around patient safety. Also, what I'd like to mention as well, there's the serious incidences. We're doing so much work at CNWL to ensure that the bereaved family member, the carer, and I can't remember who said it, was it you, Henrietta? There's a massive, it's not just the individual, is it? It's everybody around that individual. It's far-reaching, to their work colleagues, to people in their neighbours in the community. This it affects everybody when a serious incident occurs. We're doing great work around that to ensure that the patient's voice is heard. And I'm very proud to say that rather than having a family liaison officer, which is very, very similar and in fact in line with the Metropolitan Police, we have now, based on my recommendations, changed that terminology to a named contact. So an individual will have a named contact. That makes it personal, that's showing willing that you have got somebody who will listen to you. It's not just a liaison officer that's going to liaise between you and indeed the trust. And I did see in the comments that somebody has been extremely triggered by having to attend multiple serious incidences. And I know, as a bereaved mother, and I'm so sorry that this has happened to you, my experience of that is it's absolutely soul destroying, and you just really do feel let by everybody. So we want to avoid that. So serious incidences for us is a top priority.
Thank you, Tracey. And Henrietta, we couldn't, when we were having a pre-brief before, we couldn't remember which country it was, but one country, they have over 600 patient safety partners. So this is sort of sharing these insights and creating it into something where there's a collective view, but almost part of a social movement for change around patient safety. I think we're on an earlier start of the journey, but you've outlined that beautifully, Tracey, the opportunities there is here to make such a big impact. Henrietta, your thoughts for the next year, 5 years? I know you've got a 3-year term, but for the role, what you're asked, what your reflection, what your plans are.
Thank you so much. I mean, from my perspective, I think we need to see a real rebalance of the power differential between patients, families and service users and the staff and the organisations who are providing care. And this is about seeing health as an ultra-safe industry along the lines of airline, nuclear, oil and gas, so that we actually have a safety culture that permeates through the entire system, from politicians, government, citizens, and everyone being seen as part of the solution. And that requires leaders to take an active ownership of patient safety, not to delegate it to different parts of the organisation. And we need to have a just culture where people aren't blamed for an error or for a system problem, but for reckless violations or for criminal activity. And part of that means that we need the leaders of the organisation to understand about safety. I'm really keen that non-exec directors all get training on patient safety. I was on a trust board and we had training on finance and on data and all sorts of wonderful things, but there was no training on patient safety. And that means that non-execs lack that ability to ask the questions or see when things are missing in the information that's being brought to them at board by the executives. I'd also like to see a move towards restorative practice, as some countries and some organisations like Merseycare have really pioneered. I feel that the process of complaints where there's no national learning, and also when it comes to having the voice of patients is seen as worth less than the voice of staff when an incident is designated and investigated. So from all of these aspects, there's something about the overall culture that we're working in, moving away from the blame culture to a just culture that then frees people up to be able to raise their concerns, know that it will be listened to and taken forward. But I also want us to have a more understanding as professionals, as I'm a GP myself, that we're not as good as listening as we think we are. We think we're good at listening, but we can never understand the perspective of a patient without asking what matters to you, thinking about the context when it comes to consent, thinking about the impact of decisions on that individual, the time of appointments, the language that an outpatient's letter is written in. These are things that we'll only know if we actually ask. And that is a culture change. But I think part of this, and we've been hearing about different ways that the patient safety partner role has been set up. This is about standardization, and I think we're not very good at standardization across the NHS. Every organization and little cultures within it do things in their own way. And there's benefits in that, but as somebody said during the meeting I'm in at the moment, everything has a plus and a minus. And I think the downside of that is that as patients move from one part of the health system to another, the language is different, the expectations are different. As staff move from one part of the health system to another, they have to relearn a whole new system of doing it. And so that puts barriers into place. So if we can get a more standardized way of doing things, then I think that that will help in many different aspects and won't detract from some of the benefits in terms of patient safety.
I was going to reflect a little on culture, but you've said that beautifully, Henrietta, so I'm not going to dwell on that, but it is an incredibly important view. I'm going to pick up two, maybe three things. One is kind of a thread that comes through is around the leadership for patient engagement and organizational leaders that are supporting and encouraging, and having it as a policy is one thing, just making it happen. It does need to be supported, coaching, mentoring, leading, encouraging, and we've had great examples. Mel from Kingston has done some superb work, and the team down there are really making a difference, and you do need that drive organizationally to make that role successful. And I think fundamentally it's about not just the listening, but hearing and then acting and learning from that. As you say, an equal voice. So it's not just the patients and families in the corner. It's an integral part of understanding what the opportunities, but what the challenges are for patient safety, and then combining with as a sort of multi-professional group or a partnership, either as a multidisciplinary team, but a service level or as a board, as a policy level, using that insight to learn and act and improve, and then evaluate that impact and being able to demonstrate making a difference. And so I think it's very important that those frameworks put in place, that we're monitoring the value and sharing the knowledge from that. And my last point which will be making sure that we design this at every level. We've had a big change, organizational change with the establishment of ICBs and ICSs. And as some of you will know, we wrote a report earlier this year called The Elephant in the Room, because patient safety is not a specified objective or priority of ICSs. I'm sure it will be implicit in everything they do, but unless you have patient safety and patient engagement right as an organizational core, then it's unlikely to achieve the ambition that we all know is needed. So that's the end of my comments and our panelists' comments. And I think now to sort of pick up some of the comments in the chat, which I have been looking at. Mark, I think you're just going to drop me a note so I can make sure I pull them all together. But I have what was the one? I was wondering you all to it's come up in the chat as well as our discussions about listening but not re-traumatizing, and Tracey, maybe you could pick up, and then how do we make sure that we're not, by listening, we're not making it more difficult for the person that's telling their lived experience, and what support is there for them? How can we do that with compassion, but nevertheless give people the opportunity to share their insights and their experience?
Yes, thank you. Great question. So I have put this forward to our safety team, and that's one where we would expect when we first engage with whether it's our GP or if it's A&E or specialist service, that the information that we share with them is indeed collected in a way that is recorded with clarity and not professional terminology, or medical terminology, but more in a more layman's term approach, where that information then is collated and kept on the system. That should be shared, knowing that this individual will be accessing other services, especially if a referral has been put into place. So for that patient then, when they go to a new department, or indeed another hospital, as Henrietta quite rightly said, that information will already be on the system. And it's not a case of that patient having to start from the very beginning all over again, but it's for them to pick the parts that they want to express more about, that are more relevant to the care that they're going to receive within that department, or indeed a follow-up call. So having that information follow the patient all the way through the system. By reliving and resharing every time, it's compounded trauma every single time. And what that also we have to worry about, the risk that comes with that, is you've got to be mindful of not triggering somebody with PTSD. And also, if you're reliving and reliving and reliving, you can almost become detached from the reality. because you're constantly sharing. So it's almost like, as Jono said earlier, which we don't want to use that word, storytelling.
Yeah.
You just becomes part of what you say, and that's never how it should be. So I do think that the information that's stored is collective, it goes through. And I know that quite often, in my experience, where I've met somebody for the first time, they do have a lot of this information, but they don't come forward with that information. They're not sort of letting me know that they know. And they wait, and I guess that's being trepidatious and cautious, and I totally understand it as well. But that's this gap that we have between the patients and the professional. We need to bridge that gap. So it just needs to be a little bit more. What's the word? I'm struggling to find the right word for it. But I guess compassionate. I think staff who really have a huge job. I mean, there's so many patients, there's so much to do. They have to respond very quickly. Are they allowed to have that space to actually engage with the patient a little bit longer than generally? And I think that needs to be looked at. I think staff need to be encouraged to have even a minute or two, because a minute or two with the right words can make all the difference between a patient leaving an appointment happy or happier or relieved or feeling safer than leaving feeling frustrated, angry, not heard, not listened to. I think that hopefully that's answered that question.
Thank you. It has indeed. So, Jono, you might want to reflect. There's another question I want to pick up, Henrietta, on something else. So I'm just going to ask Jono to pick up if there's anything you would want to add to what Tracey says, both in terms of your professional role in supporting kind of people with lived experience, as well as your personal experience of the care system.
Yeah, so first of all, Tracey is absolutely right. If you relive it and speak it constantly, it becomes a repetitive exercise that doesn't actually help you or anybody else. So for me individually, when I'm sharing my patient stories where things have gone wrong for learning, actually I've now recorded most of those so that I don't have to go through the thing of actually saying it constantly, and I can just refer people to it, and then I can talk to them about any questions they have, which is for me a slightly better way of doing it. I've also seen that work really well with some of our national teams who do look at patient stories. And I use that term in knowing that I mean evidence and I mean experience. The other thing that Tracey rightly picked up, and it could be put into my list of, oh my God, desires for one day, please, because I know it won't happen straight away. But currently I have no legal right to add to my patient record. We call it a patient record, but actually it is a hospital or organisational record about a person, written by other people and never challenged or being able to make comment on by the person it actually involves. And so I would like to see that when organisations create records about them, that they are combined into a patient-held digital record, that the patient can decide whether or not they add to it, put a note about what has been said, give their recollection of actually what happened. And so I believe that whilst we've never been able to do this really well in the sense of organise ourselves for electronic patient records or records as a whole, I remember 15 years ago being involved in what was called the NHS Spine, which was a financial catastrophe. We should be thinking about asking patients to hold and digitally have access to everything that is ever written about them, and being able to actually add to those notes, not just holding them and saying to somebody, here you are, you can now add to it. So that would be one of my things for the future as well.
Thank you. And that may be something you want to comment on, Henrietta, because there's been a lot of talk the last few days about equalising the relationship between care providers, professionals and patients. And some of that is through equal access to information, as well as addressing the power imbalance. So you may want to comment on that, but the question I specifically got, which I've lots of discussion in the chat, and we will kind of try and respond to these separately in the kind of write-up afterwards. But Henrietta, you mentioned Royal Colleges, and these are from our colleagues from who are talking about outpatient hysteroscopy, who I know you've been actively really engaging in. But more generally, when you mentioned about engaging with Royal Colleges, I think the campaign for outpatient pain-free hysteroscopy have struggled to find out how to best engage with Royal Colleges. Do you have any advice more generally about how patients who may want to be raising concerns with around clinical guidance or best practice, how they should do that? Is there any advice you could give there?
Yeah, thank you very much for the questions. I'm just going to start with the bit about patient involvement, if that's okay, on the basis that the recent report was published, and I'll put the link.
Oh, you've gone on to mute.
You've been muted, Henrietta.
Thanks, sorry, press the wrong button. I was just putting something in the chat, which is a report about different ICSs and the level of meaningful patient involvement. So I was just thinking, for people who are on the call, if you want to have a look, there's a lovely map in it which sets out which ICSs have been deemed as green, amber or red, and you might be able to share that with your ICS leads just to say, look, you know, what's happening here and how can you learn from the areas that are green. So that's just on the patient involvement aspect. In terms of Royal Colleges, what I've discovered is that Royal Colleges have their own patient panels. And so I've been able to get involved with, for example, the Royal College of Physicians. We've been talking to the Royal College of Anaesthetists, and I talked to the Royal College of Obstetricians and Gynecologists, Surgeons of England, etc. So there's lots of different Royal Colleges, and they each have their own different approach. When it comes to guidelines, I think there's a difference. I just wanted to, set out the difference between a guideline and then the commissioning of a service. And so, I have raised the question about painful outpatient hysteroscopy. I mean, I used to do obstetrics and gynecology when I was a trainee, and there were lots of different painful gynecological investigations, which, I have to say is horrific for people who are offered a treatment or an investigation, and then discover at the point when they're having it that it's extremely painful. And it might be extremely painful for them and not for somebody else, but that is their experience. And I've received a lot of information about this, and it has my enormous sympathies, and I have escalated it. And I think that is the difference between the different parts of the siloed, disjointed system that Baroness Cumberledge set out in First Do No Harm, and who's got responsibility for what. So I think that what we have to do is actually say, look, it's about understanding and listening to the voices of patients, having that early detection of harm, and then the swift action as a result. And when multiple thousands of patients are saying the same thing, then the system has to listen and act, and not be, well, I've done my bit, so we're fine. It's about how that system comes together to actually, move forward and find a better solution. So I just wanted to say that a lot of the individual issues that have been raised in the chat, whether it's about painful gynecological investigations, and in terms of the treatment of hypothyroidism, these are issues that have been raised to my office, and we have escalated them to the parts of the system who have the power to do something. And some of the responses I've had have been really positive when it comes to MHRA and the way that they now involve patients in looking at individual medicines and the side effects and risks. I think they've really taken quite a new approach to that. And others I've been, let's say, that I don't see so much movement happening. But I also have to recognise that my team, is now a year old, and we're refreshing our strategy in terms of where are the priority areas that we're going to be looking at. And thank you very much, Eleanor, for putting your details into the chat as the Patient and Public Involvement Manager at the Royal College of Anaesthetists. So I would encourage patients, activists. I know that there's a difference between an advocate who speaks and an activist that do. And I think we've got some fantastic patient activists here on the call who are putting things into the chat, and I would be happy to help link to the right bits of colleges if you're finding that you're getting stuck.
Thank you. And I think also my experience is a number of the Royal Colleges have actually got dedicated patient safety committees as well. So you can go through the public involvement engagement route as well as the patient safety committees. And I recently joined the Royal College of Surgeons of Edinburgh on their patient safety committee, and they do have a specific patient kind of representatives as part of that. So they, as you say, they're very different, the Royal Colleges, but there are ways through. Maybe we should encourage people to report on that, so it's easier for them to find a way through. I'm going to come back to, so patient safety learning, we talk about patient engagement at sort of 4 levels, at the, at the point of care, shared decision making, informed consent, if things go wrong around investigations and learning, for improvements, and for advocacy activism around campaigning. So those 4 levels. But there's a question in the chat which goes right down to the individual patient engagement in their own care, and the question is around multidisciplinary teams. And I think there's been a lot of focus, in my view, rightly, about patients and family members being seen as part of a multidisciplinary team, so that the decisions aren't being made about them and then communicated to them afterwards. They're actually contributing to that. So I think there's a lot of strength in that. So I would welcome your comments on that. But the particular question, which is a little more, which is quite a little challenging around how to do that, is that there is, someone says there is evidence that patients engaging with multidisciplinary teams as a whole is often intimidating for the patient. So some reflections about the role of patients within a multidisciplinary team and how to enable that to happen as effectively and as compassionately as possible. So I don't know who'd want to go first on that one.
Yeah, so I actually responded to that in the chat as well.
Oh,
Helen,
did you?
so
Okay,
that's
right.
fine. But my understanding is, yes, there is some evidence that patients find it daunting, find it stressful, and my answer or my response to that generally is, it's how we enable patients to be involved in it. If you keep it as happened to me once, and I found it intimidating, a circle of doctors and clinicians in a chair in a round circle, where the patient's invited in, sat on a chair in front of them like an interview panel, and then told what they've done wrong in their healthcare and why they haven't been a good patient. That's not a caring and great environment for a patient to be invited into. If you actually invite them in as an equal and ask them for feedback about the care that they have received, as well as what they would like to know in order to support their care, then actually I think we can give good support to patients to be involved in MDTs. As a patient with cystic fibrosis, actually, I have the privilege almost of meeting all my clinicians at one outpatient's appointment, because we have to be looked after in sense of infection prevention control reasons. But they still hold MDTs about us, where I hear afterwards, oh, by the way, we discussed you, and by the way, we thought you might like to change your medication to X, which is utterly ridiculous when you've met with me all in the whole and you didn't discuss that with me while I was there. So yeah, it is a thing about how we prepare patients for it, how we involve them in it, and how we support them, enable them to have other people with them maybe while they're in front of that team, and how we make it an inclusive MDT rather than anything else. And I understand there are often issues where clinicians will raise, actually, we do need to have a private conversation because there are things that might have real concern for the patient, and we need to discuss how we're going to raise those. I'm not saying you can't have private conversations. I'm saying when there is an MDT that's discussing a patient in the way that says, actually, it'd be nice to have them in the room, and I don't want to have something reported to me afterwards. It's about the care we put around it, not just the go on then, let's open the door and let them in routine.
Yeah, thank you, Jono. A very powerful example. And Henrietta, you've already answered or responded immediately to that in the chat. Nothing about me without me, and lots of thumbs up and hearts on that. I'm going to come to Tracey for the final point, but Henrietta, do you want to say a little bit more about that, and particularly given, as a primary care physician, I mean, this is shared decision making is something that is very much kind of normalised in general practice. I would imagine. Anything you want to add to that? And you're on mute if you do. Oh, there you go.
No, I would like to hear from Tracey.
Okay. Yeah, we've probably got 1 minute left. So Tracey, you can wrap it up with whatever comments you want to make about this or anything else. Oh, you're on mute. You're on mute.
And I was doing so well on off. There we go. I'd just like to echo, and thank you, Henrietta, for allowing me to speak at the last minute. For the last minute, not at the last minute. I'd just like to echo everything Jono said. Actually, it's absolutely, that's it in a nutshell. And I also think the name contact, who's been with the patient throughout, that there's this open and transparent correspondence, involvement where indeed the patient wants to be involved and where it's appropriate. Because if this is about a member of staff, that situation, and we've got to consider human factors, you know, that could not end well for either human being on a human level. So I do think, yes, there needs to be transparency. The patient absolutely needs to feel confident, be able to sit amongst professionals. You know, it is extremely daunting, and one could almost feel that there's a huge amount of pushback if you speak about your experience, how you're feeling, because there's a disconnect quite often in that situation where, you know, the team is damage limitation. Let's be honest here, it's what's happened, the facts. How do we move forward so that maybe the patient doesn't sue the trust? Or, you know, there's a lot more going on there. So I just think transparency, openness, name contact, who's supporting the patient, to also sort of encourage the patient and help them to magnify the point, or, you know, bring to the board or to the investigation exactly how this has impacted them. Because what we need from all of that, and the outcome is that that there's learning to be taken from that. So it's the learning, it's the opportunity. What can be done from this incident that should not have happened? What can we do to make sure that doesn't happen again? So again, here's another opportunity to involve the patient in that development piece moving forward, you know, having their voice, including them in being part of that change moving forward.
Thank you. That's a perfect ending to the session, and I'm going to do thanks hugely, Tracey, to you, to Jono, and to Henrietta for joining us today. Fabulous that we've got. I mean, there were 200 and something or other people. A couple of people have dropped off because we're running a little bit over time, but so many that have joined us, actively engaged in the conversation. And I do wonder, maybe we come back in a year and do this again, and just say, well, how's this last year gone? I mean, I'm sort of like bouncing you all into it, so we'll have to think about that. But really, I think we've seen significant progress in the last year. There's a lot of positivity. There's lots more to do, but I think with the commitment of people that have joined the meeting and commitment to make this real, in Tracey's words, for this to be about learning and acting on that learning for improvement. That's what we're all about. So just so appreciate everyone joining us, and happy World Patient Safety Day on the 17th on Sunday, and look forward to having further conversations going forward. Thank you.
Thanks so much.
Thank you,
Thank you,
everyone.
everyone.
Bye.
Bye. Bye-bye.